Hi, I'm Dr. Kerry Ambrogio, and the purpose of this video clip is to introduce to you the concept of muscle energy. Muscle energy is a direct technique. We had talked about position release therapy in another video, and that's an indirect technique. An indirect technique is where you take the body part into a position of comfort. A direct technique is directly opposite. We take them into a position of tension. So for example, if I was to work here on Angie and I found a problem, let's say on L5, I'm going to palpate L5 with my left hand. If I were to rotate her body to the left and to the right, she moves easy to the left. So if I want to do position release therapy, I could just hold her there. But she has a difficult time moving to the right, so I'll take her to that barrier. And in muscle energy, we want to use the muscles to create a barrier. One hand is always on the joint we're treating. And I want to get the muscle energy part is the muscle contraction. So I'll say, don't let me move you. So I'm going to push her to this direction and hold it about 6 to 8 seconds. When she relaxes, I'll then mobilize a bit and I'm going to move to that next barrier. So muscle energy is a direct technique where we're going to focus on treating joint hypomobility, joint stiffness. When we release that, we also soften hypertonicity in the muscles. We soften the fascia. When we reorganize all this, we're actually improving blood flow, venous return, lymphatic flow, and also energy flow. We're creating a better environment for healing. Okay? So muscle energy was originally developed by Dr. Fred Mitchell Sr., who's an osteopath. He later passed on his information to his son, Fred Mitchell Jr., who progressed the information. So how do we evaluate if someone comes to you with joint hypomobility or joint stiffness? And how do we know they would benefit from muscle energy? See, muscle energy works best if you're treating someone with joint stiffness or hypomobility. So what we have to do is we need to use our evaluation, our subjective and objective. If it's subjective, we need to find out, did she have a mechanism of injury, right? Is this acute? Is this chronic? What stage of healing is she in? Is this a sprain, strain type injury? Most of all, we have to go in with the objective evaluation. And we talked about it in the introductory video, ARTS, A-R-T-S. So the first letter, A, stands for asymmetry. So let's take a look at Angie. Let's say we evaluate her iliac crest, and she may be a little bit higher on the right side. We could look at the anterior superior iliac spine, so I place my thumb on the inferior portion, and I'm looking for rotations. And she has a little bit of an anterior rotation. I can also look for flares. I can put my thumbs on the medial aspect of the SIS, and I'm put my index finger in her belly button, and I'm looking for this movement, this flare on this transverse plane. So let's say she has a little bit of an out flare here, and she's got a little bit of an anterior rotation. I could also evaluate the pubic tubercles to see if they're lined up. So when we look at all this asymmetry, we know that the more asymmetrical Angie is, the more it's going to affect her functional range of motion. But what we don't know is what's causing it. See, this could be caused by protective muscle spasm, if she had a tender point there. It could be caused by joint hypomobility, joint stiffness, or fascial tension, or swelling, or something else, or emotional issues, consciousness issues in the tissues. So what we have to do is progress with our evaluation. So we've done the A part, so now we have to go to the R, which is restriction and range of motion. So now what we would do is I can evaluate this iliosacral joint, and I can begin to evaluate different movements, abduction, adduction, maybe a little bit of straight leg raise. I could then begin to evaluate hip extension, hip flexion. Okay? So in muscle energy, we always have our hand on the area we're trying to evaluate, and I'm using a long lever here to see what happens. What's the nature of the barrier? Typically, if it's a joint dysfunction, what I'm going to find is that when I start to move her in a certain position, it's like if she has an anterior rotated innominate, let's say, on this right side, she is going to like extension, but she's not going to like flexion. And a lot of times I might feel more of a firmer or more of a hard type end feel in here. So that gets me thinking that this could be more joint. But again, I've got to continue with my evaluation. We go to the T part. The T part is actually going in there and actually physically doing tension tests, checking the iliosacral joint, checking the pubic joint, checking the hip joint. I'm looking for tension. If I feel lots of tension in this area, I know she has joint hypomobility and would probably benefit from muscle energy. She also may have some increased tissue texture, but if it's typically a joint problem, she could have tenderness, but it's not going to be that high level that I would typically want to find for position release therapy. We have the S component, the special test. We have lots of special tests we're going to teach in this class. Standing forward bending test, kinetic test, all sorts of different tests for the sacral, a sacral rock type test. And these tests will help confirm different types of joint hypomobility. So let's say, Angie does have a problem. She does actually have an anterior rotation here. So let's walk you through the steps of how muscle energy would create this problem. So we found the problem by using ARTS, A-R-T-S. She has an asymmetry where this right innominate is rotated anterior. I can see the anterior superior spine is lower on this side. So typically, if someone has an anterior rotated innominate, they're going to like hip extension. So step number one is I'm going to just slide my hand underneath so I'm in that iliosacral joint, just medial to the PSIS. I'm going to come in here, grab her leg, and I'm going to come down in an extended position. And she should like this, which she does. As I come up, I'm feeling for where is that first barrier. And she has a little bit of a barrier right here, and I'm feeling with my left hand. If I want to, I can treat on this plane. I can say, don't let me move you. And what I'm doing is I'm getting her to engage her hip extensors and relax. So that's typically using her agonistic muscles. If I wanted to, I could say, don't let me bring you down, and she'd be using her reciprocal muscles. So you could use either one. You use the one that gets you the best results. Typically when we do this muscle contraction, we're going to hold it 6 to 8 seconds. When she relaxes, I like to go through the range of motion. Okay, I like to move that in and out as we go through, and then we typically repeat this 3 to 5 times. Now with muscle energy, you can treat on one plane, just like I did here, or I could add another plane. I could add adduction or abduction. What does she like to do? What doesn't she like to do? Let's say she doesn't like to abduct. So what I could do is I could flex her up to that barrier, and I could add or abduct, and I could say, don't let me move you. So I'm using her adductor muscles, so the agonistic muscles, and relax. Or I could say, don't let me move you, and I could be pushing her inwards using the reciprocal muscles, and relax. So use what works the best. The other motion I could use would be rotation, external or internal. So typically with muscle energy, you could use 1, 2, or 3 planes. I like to use 1 plane or 2 planes. 3 planes tends to tie things up too much. So I would either use flexion with either abduction or adduction, or I would use flexion with rotation, whichever one was more compromised. And then don't let me move you. I would hold her there for that 6 to 8 seconds and relax. When she relaxes, I like to go through that range of motion a few times, move to the next barrier on the 1 or 2 planes, and I repeat this 3 to 5 times. Once I'm finished, I pull her down, and you want to reevaluate. So you go back to the asymmetry. She should look better. She should have better alignment. Okay? I should go back and reevaluate the range of motion. We should see better range of motion. Okay, and all the different movements. We go to the T, the tension test. It should move much easier afterwards if I were to do the tension test. The tissue texture should feel better. And if she had a little bit of tenderness, that should be better. And if I did any special tests, when I go to reevaluate, what I would see is an improvement in that special test. Okay? So when you come to the Ambrogio Institute, we offer muscle energy in 2 different ways. We can do muscle energy for the lower quadrant, or we can do muscle energy for the upper quadrant. In the lower quadrant, we're typically going to work on the lumbar spine. We're going to work on the pelvis. We're going to work on the hips, the knee, ankle, and feet. Muscle energy for the upper quadrant. We're going to work on the cervical spine, the thoracic spine. We're going to work on the rib cage, the shoulder, elbow, wrist, and hand. Typically, muscle energy is going to be taught in a 3-day format. We're going to offer CUs. You're going to get a highly illustrated manual to help you with your learning. We're also going to set up a review DVD for you afterwards that you can consult with. And we hope to see you at this course in the future.